Neonatal lungs are uniquely fragile. The combination of surfactant deficiency, fluid-filled alveoli, and a highly compliant chest wall makes them prone to both collapse and overdistension with each conventional breath. Conventional mechanical ventilation, even when carefully adjusted, exposes the lung to cyclic pressure swings that create ventilator-induced injury. This injury develops through several mechanisms: volutrauma from excessive tidal volume, barotrauma from high peak pressures, atelectrauma from repetitive opening and closing, and secondary inflammation known as biotrauma. Over time, these processes contribute to bronchopulmonary dysplasia and impaired long-term lung growth. High-frequency ventilation was developed to minimize these injuries by maintaining the lung in a more constant state of inflation while still supporting gas exchange. Instead of large tidal breaths, the ventilator delivers extremely small oscillations around a steady mean airway pressure. This stabilizes alveoli, limits shear stress, and reduces the amplitude of pressure transmitted to the pulmonary microvasculature. Gas exchange occurs through enhanced mixing rather than bulk tidal flow, allowing effective oxygenation and ventilation at much lower pressure swings. Clinically, the goal of high-frequency ventilation is not to normalize numbers on the screen, but to preserve lung structure and prevent injury. When used appropriately, it maintains functional residual capacity, improves ventilation, perfusion matching, and reduces exposure to high oxygen and excessive pressure, key factors in protecting the preterm lung. High-frequency ventilation replaces the conventional pattern of large, slow breaths with very small pressure oscillations delivered hundreds of times per minute. Each oscillation occurs around a constant mean airway pressure that holds alveoli open throughout the entire respiratory cycle. By avoiding repeated opening and closing, the lung remains within its most stable range on the pressure-volume curve, which minimizes shear forces and limits the inflammatory cascade that drives chronic injury. The essence of this strategy is lung stability. Oxygenation depends primarily on mean airway pressure because it determines the number of alveoli that remain recruited and available for gas exchange. Carbon dioxide clearance, on the other hand, is determined by the amplitude of oscillation and the frequency of those oscillations. Small changes in either variable can have large effects on ventilation efficiency. This separation of oxygenation and ventilation control allows clinicians to manage gas exchange more precisely while keeping pressure swings minimal. From a bedside standpoint, high-frequency ventilation functions best when the lung is open, stable, and evenly inflated. The clinician's role is to maintain that balance, adjusting mean pressure to sustain oxygenation while modulating amplitude or frequency to fine-tune carbon dioxide removal. This approach provides effective ventilation with less mechanical stress, supporting lung protection as the central goal rather than simply achieving normal gas values. The pressure-volume curve illustrates how alveoli respond to applied pressure during inflation and deflation. At very low pressures, alveoli remain collapsed and oxygenation is poor. As pressure rises past a critical opening point, alveoli begin to recruit, and small increases in pressure result in large increases in lung volume. This segment represents the optimal portion of the curve, where alveoli are open and compliant. Beyond that, as pressure continues to rise, the lung reaches an over-distended range where additional pressure adds little volume but increases the risk of injury. High-frequency ventilation aims to keep the lung operating on that optimal middle portion of the curve. The mean airway pressure is set to maintain alveolar inflation just above the closing point, preventing collapse during expiration. By oscillating around this baseline, the lung remains open and stable, avoiding the constant recruitment and de-recruitment that causes atelectrauma. Clinically, this principle guides how we titrate mean airway pressure. A gradual rise in mean pressure improves oxygenation by recruiting more alveoli into the gas exchange region of the curve. However, increasing pressure beyond the upper inflection point compresses alveolar capillaries, impairs venous return, and worsens oxygen delivery. Recognizing where the patient lies on this curve helps the clinician determine whether to increase mean pressure to open the lung or reduce it to avoid overdistension. Maintaining the lung in this narrow optimal range, the open but not overinflated state, is the foundation of lung protection in both high-frequency and conventional ventilation. Ventilator-induced lung injury represents the cumulative effect of mechanical stress on immature or diseased lungs. Several overlapping mechanisms contribute to this injury pattern, each driven by how pressure, volume, and flow interact with delicate alveolar tissue. Volutrauma occurs when excessive tidal volume stretches alveoli beyond their elastic limits. In neonates, even small changes in delivered volume can double wall tension, leading to epithelial disruption and surfactant deactivation. Barotrauma results from exposure to high peak pressures that damage the airways and interstitium, predisposing to air leak syndromes such as pulmonary interstitial emphysema and pneumothorax. Atelectatic trauma arises from repetitive alveolar collapse and reopening with each breath. This cyclic shearing at low lung volumes causes focal injury even when peak pressures appear modest. Biotrauma describes the inflammatory response triggered by mechanical stretch. Cytokines released from over-distended or repeatedly collapsed alveoli spread injury to adjacent, otherwise healthy tissue, and may extend systemically, contributing to multi-organ inflammation. Together, these processes form a self-reinforcing cycle. Collapse promotes over-distension of the remaining open units, which then drives further inflammation and loss of compliance. Over time, this cascade remodels the developing lung, leading to fibrosis and arrested alveolar growth characteristic of bronchopulmonary dysplasia. High-frequency ventilation targets this problem by limiting tidal excursion and stabilizing alveoli near their optimal volume. By avoiding large pressure swings and minimizing repetitive opening and closing, HFV interrupts the mechanical triggers of lung injury and supports recovery within an open, stable lung configuration. Every respiratory system has a natural frequency at which it oscillates most efficiently. This is known as the resonant frequency, determined by the combined compliance and resistance of the lung and chest wall. When ventilation occurs near this frequency, less energy is required to move gas because the mechanical properties of the system align with the oscillatory pressure wave. At frequencies far above or below resonance, efficiency declines and greater pressure is needed to achieve the same tidal excursion. In neonatal lungs, the resonant frequency is relatively high because compliance is low and resistance is moderate. High-frequency ventilation takes advantage of this characteristic by operating at or near the lung's natural oscillatory range, allowing effective gas exchange with extremely small volume displacement. The goal is not to match resonance precisely, but to select a frequency that balances carbon dioxide clearance and lung stability. Impedance refers to the total opposition of the respiratory system to oscillatory flow. It incorporates both resistance from the airways and elastance from the lung parenchyma. As frequency increases, impedance initially decreases, reaching a minimum near the resonant point, and then rises again as elastic forces dominate. Diseased or fluid-filled lungs shift this curve, increasing impedance at lower frequencies and reducing effective transmission of oscillatory energy to the alveoli. Clinically, this means that infants with stiff, non-compliant lungs often require slightly lower frequencies to ensure adequate gas mixing, while those with more compliant lungs can tolerate higher frequencies with smaller tidal volumes. Understanding the relationship between resonance and impedance allows clinicians to select frequency settings that optimize gas exchange while minimizing pressure amplitude and mechanical strain on the lung. Gas exchange during high-frequency ventilation does not depend on conventional bulk flow. Instead, several distinct mechanisms work together to move oxygen and carbon dioxide within the airways and alveoli, despite tidal volumes smaller than anatomic dead space. Each contributes differently depending on oscillation frequency, lung geometry, and disease state. Bulk convection still occurs in proximal airways, carrying fresh gas toward the alveoli and removing exhaled gas. Taylor dispersion enhances mixing by stretching and folding the gas interface along the airway walls during oscillation. Asymmetric velocity profiles mean that inspiratory and expiratory flow are not perfectly mirrored, which promotes net distal movement of fresh gas. Penduloft flow arises from regional differences in compliance and time constants, allowing gas to shift between lung units with each oscillation. Molecular diffusion dominates in the smallest airways and alveoli, where random particle motion completes gas mixing and exchange. These mechanisms operate simultaneously, making high-frequency ventilation highly efficient despite minimal tidal displacement. The efficiency depends on the frequency and amplitude of oscillation, the uniformity of lung inflation, and the overall surface area available for diffusion. Well-recruited lungs require less amplitude to achieve the same gas transfer because the distribution of pressure and flow is more homogeneous. At the bedside, this understanding explains why optimizing lung volume and maintaining uniform recruitment are central to the success of high-frequency ventilation. When the lung is open and stable, small oscillations achieve substantial ventilation, allowing lower pressure swings and reducing the risk of injury. When the lung becomes partially collapsed or over-distended, these gas transport mechanisms are disrupted, and ventilation efficiency declines sharply. Within the high-frequency ventilation circuit, gas flow is not uniform. The rapid oscillations create complex velocity profiles that promote mixing and enhance diffusion far beyond what would occur through molecular motion alone. This combination of streaming and mixing explains how effective ventilation can occur despite tidal volumes smaller than the anatomic dead space. During inspiration, high-velocity flow moves centrally down the airway while slower layers of gas near the wall lag behind. As oscillations reverse direction, the boundary layers do not fully realign, creating small eddies and shear zones that fold and mix the gas column. These repeated distortions amplify molecular diffusion, a process known as Taylor dispersion. The effect increases with oscillatory frequency and the length of the conducting airways, providing an efficient mechanism for distributing fresh gas deep into the lung. Another component, sometimes referred to as convective streaming, results from subtle differences between inspiratory and expiratory flow paths. Because of branching geometry and regional differences in compliance, the forward and reverse flow are not identical. The net effect is a small directional bias that continuously refreshes gas in distal regions, even without large volume displacement. These physical interactions form the foundation for effective gas exchange in high-frequency ventilation. The efficiency of mixing depends on oscillation frequency, amplitude, and uniform inflation of the lung. When alveoli are evenly recruited, flow streaming and dispersion work synergistically, maintaining stable gas concentrations with minimal mechanical strain. Disruption of this balance through airway obstruction or uneven inflation diminishes mixing efficiency and contributes to rising carbon dioxide levels. Amplitude and frequency determine how effectively oscillatory energy moves through the airways and exchanges gas within the lung. Amplitude, or delta pressure, represents the size of each oscillatory pressure swing around the mean airway pressure. Larger amplitudes generate greater tidal volume displacement and enhance carbon dioxide clearance, but increase the risk of overdistension if lung volume is already high. Frequency, measured in hertz, reflects how many oscillations occur each second. The relationship between amplitude and frequency is inversely proportional. When frequency increases, each oscillation becomes shorter, producing less tidal displacement for a given amplitude. As oscillations travel from the central airways toward the alveoli, their pressure and flow diminish through a process called attenuation. This loss of energy occurs because airway branching, resistance, and tissue damping absorb a portion of the oscillatory signal. Stiffer or smaller lungs accentuate attenuation, reducing the effectiveness of distal gas movement. In contrast, well-recruited compliant lungs transmit oscillatory energy more evenly, allowing effective gas mixing at lower amplitude and pressure swings. Understanding this balance is critical. Increasing amplitude improves carbon dioxide removal, but also increases pressure variation and potential shear injury. Raising frequency smooths the oscillatory waveform and enhances lung stability, but may reduce carbon dioxide elimination if oscillations become too small. The optimal settings for each infant fall where amplitude is just sufficient for ventilation and frequency is high enough to maintain stable inflation without compromising clearance. Gas exchange depends not only on ventilation, but also on how well it aligns with pulmonary blood flow. In the neonatal lung, vascular tone and alveolar geometry are closely linked, so even subtle changes in lung volume can shift regional perfusion. When alveoli collapse, local hypoxia triggers vasoconstriction, diverting blood towards still ventilated regions. However, if the lung becomes overdistended, capillary compression reduces perfusion to those areas, again disrupting balance. Either extreme increases intrapulmonary shunting and widens the difference between oxygen delivery and uptake. High-frequency ventilation promotes more uniform ventilation perfusion matching by maintaining alveoli within their most stable volume range. A constant mean airway pressure supports consistent alveolar expansion, minimizing both collapse and overdistension. This stability reduces the mechanical distortion of pulmonary vessels and helps preserve even capillary perfusion across lung regions. As a result, oxygen exchange becomes more efficient, and the need for supplemental oxygen often decreases. When the lung is properly recruited, each oscillation maintains gas mixing without large regional swings in volume. Blood passing through these units experiences steady diffusion gradients, improving oxygen uptake while minimizing carbon dioxide retention. In contrast, an under-recruited lung forces more blood through poorly ventilated areas, increasing shunt and requiring higher pressure or oxygen to compensate. Balancing lung volume to achieve optimal perfusion and ventilation alignment is therefore a central objective in high-frequency ventilation and a key determinant of overall gas exchange efficiency. Transitioning from conventional to high-frequency ventilation is guided by the balance between oxygenation, ventilation, and the pressures required to maintain them. The decision is not defined by a single threshold, but by recognizing when conventional ventilation can no longer provide adequate gas exchange without risking further lung injury. The most common indication is persistent hypoxemia, despite escalation of mean airway pressure and oxygen on conventional settings. When higher peak pressures are needed to achieve modest tidal volumes, the risk of overdistension and air leak increases sharply. Transitioning early in this situation allows recruitment of alveoli using a steady mean pressure rather than repetitive large tidal inflations. Hypercarbia with respiratory acidosis that does not respond to increased rate or tidal volume is another prompt for transition, as high-frequency ventilation can clear carbon dioxide more efficiently through enhanced mixing mechanisms. High-frequency ventilation is also appropriate in conditions with air leak or uneven compliance, such as pulmonary interstitial emphysema, meconium aspiration, and pulmonary hypoplasia. In these cases, conventional ventilation often worsens regional overinflation while underventilating collapsed areas. The switch to high-frequency support stabilizes airway pressures and limits further tissue damage. The transition should occur before the lung becomes extensively injured or oxygen requirements reach toxic levels. Early use can stabilize gas exchange with lower pressure swings and help preserve functional residual capacity. Waiting until the patient has already developed severe air leak or profound acidosis reduces the likelihood of success. The key is to identify the point where increasing conventional pressures cause more harm than benefit and move to high-frequency ventilation while the lung can still recruit effectively. High-frequency ventilation is selected when conventional ventilation cannot support gas exchange without exposing the lung to injurious pressure or volume. The first indication is rescue therapy for refractory oxygen or carbon dioxide problems, despite appropriate conventional adjustments and surfactant when indicated. Moving to high frequency before further escalation in peak pressure limits the risk of air leak and avoids repetitive opening and closing of unstable units. Early elective HFOV is reasonable in severe respiratory distress syndrome when the goal is gentle ventilation with stable lung volume from the outset. HFOV maintains a steady mean airway pressure to recruit and hold alveoli while using very small oscillations to control carbon dioxide, which reduces shear from large tidal swings. In parenchymal disease, such as meconium aspiration, pneumonia, or persistent pulmonary hypertension, high frequency can restore uniform inflation and improve ventilation perfusion alignment when conventional breaths are creating overinflation in some regions and underventilation in others. Infants with very low compliance, including pulmonary hypoplasia or restricted chest mechanics, benefit from an approach that preserves functional residual capacity without large pressure excursions. In these settings, selecting the mode based on the dominant physiology is essential. HFOV favors homogeneous disease that requires recruitment and steady volume because inspiration and expiration are both active and mean. pressure is stable. HFJV favors heterogeneous lungs or air leak-prone conditions because the short jet pulse and passive exhalation allow effective carbon dioxide clearance at lower mean pressure with less risk of further leak. Mode selection therefore follows the pathophysiology. Choose HFOV when uniform recruitment and stable mean pressure are the priority, and choose HFJV when unequal time constants or air leak demand lower mean pressure and precise control of carbon dioxide. High-frequency ventilation is not suitable in situations where its fundamental mechanics would worsen instability or prevent effective ventilation. The most important contraindication is unsecured or obstructed airways. High-frequency systems depend on a patent, well-seated endotracheal tube to transmit oscillatory pressure. If the tube is displaced, kinked, or partially blocked by secretions, gas cannot move efficiently and rapid hypercarbia or air trapping can occur. Before initiating high frequency, airway position and patency must be verified. Another absolute contraindication is untreated pneumothorax or significant air leak without chest drainage. High mean airway pressure and active oscillation can force gas through the rupture site, enlarging the leak and risking tension physiology. A functioning chest tube is required before beginning high-frequency support if any pneumothorax is suspected. Severe hemodynamic instability, unresponsive to volume and inotropes also limits use. Because mean airway pressure remains constant throughout the cycle, venous return can fall sharply in infants with marginal cardiac output. Until perfusion and blood pressure are stabilized, switching to high-frequency ventilation can worsen systemic oxygen delivery. Finally, upper airway anomalies or congenital diaphragmatic hernia with unrepaired visceral herniation may preclude use of certain high-frequency modes. In these conditions, pressure transmission is unpredictable and may further compromise the contralateral lung or cardiac filling. Absolute contraindications, therefore, reflect scenarios where oscillatory pressure cannot be safely transmitted or where the fixed mean pressure would jeopardize circulation. Each must be corrected or stabilized before high-frequency ventilation is considered. Relative contraindications describe situations where high-frequency ventilation can be used but carries increased risk or reduced effectiveness. The first is severe airway obstruction, such as meconium plugs or bronchomalacia. Oscillatory flow depends on unobstructed, symmetric airways. Resistance dampens pressure transmission and prevents adequate carbon dioxide clearance. If obstruction is present, it should be relieved and compliance optimized before switching modes. Profound hypocarbia is another caution. High-frequency ventilation is highly efficient at removing carbon dioxide, and infants who are already hypocarbic can worsen quickly, reducing cerebral blood flow and risking intraventricular hemorrhage. Settings must start conservatively with close monitoring of blood gases. Unstable pulmonary hemorrhage presents a challenge because oscillations can dislodge clots or worsen bleeding when mean airway pressure is elevated. Once hemostasis is achieved, HFOV may still be valuable to stabilize oxygenation, but initiation during active hemorrhage should be avoided. Significant right-to-left shunting in persistent pulmonary hypertension is a relative limitation, particularly for HFJV. Excess mean pressure can compress capillaries and raise pulmonary vascular resistance, worsening shunt fraction. Careful titration and concurrent vasoactive management are required. Finally, severe metabolic acidosis or systemic hypotension reduce tolerance for changes in intrathoracic pressure. Stabilizing perfusion first prevents secondary cardiovascular compromise when mean pressure is applied. These conditions do not absolutely preclude high-frequency ventilation, but require caution, corrective treatment, and close monitoring to ensure that the potential benefits outweigh the risks.